Good evening, everyone, and welcome to my GAP MASLD MASH Community Network Hub. It is my opportunity to speak to you this evening, and it is a great opportunity to be able to speak with you all regarding pharmacokinetic therapy with MASLD and MASH. My name is Jeremy Davis. I'm an acute care nurse practitioner. I practice a gastrointestinal specialist out of Shreveport, Louisiana. Please feel free to use this QR code to record your attendance for this meeting this afternoon. So our topic of discussion this evening is going to be MASLD pharmacotherapy. So current treatments available for dysmetabolic management, what we know of that we've talked about in the past is weight loss, as far as lifestyle modifications with diet and physical activity, also implementation of weight loss medications, the possibility of bariatric surgery with some of the patient population, but also in the newer mechanisms, we're looking at GLP-1 receptor agonist as well as GLP-1 GRP receptor agonist. And also you're looking at other older pharmacokinetics such as vitamin E, except for diabetes, Pioglitazone, and now Resmetirom that's been approved as of last year. So when you look at this picture, you're looking at this overview of what our goals are as far as management and treatment for dysmetabolic management. We want to control obesity. We want to reduce cardiovascular disease risk. So if someone has hyperlipidemia, then implementing strategies in order to get those lipid panels under control would be very important and helpful. Sometimes we do this amongst ourselves in the hepatology community, but also in primary care, we tend to rely on primary care as well as other subspecialties that can include cardiology, endocrinology, management of hypertension, and dyslipidemia. So there's a big circle that evolves around what we're trying to do. So if we control obesity, reduce the cardiovascular disease risk, then we can also have an impression on targeting NASH. And it's just a full circle of opportunity of keeping things under control. So let's discuss GLP receptor agonist. After food ingestion, endogenous GLP-1 stimulates glucose-dependent insulin secretion. It can suppress glucagon and delay gastric emptying. This directly acts on the hypothalamus to promote satiety and reduce energy intake. GLP-1 receptor agonists are analogs of the gut-derived incretin hormone, glucagon-like peptide 1. So we know that bariatric surgery in the past and use of GLP-1 receptors are truly groundbreaking ways in providing a way to achieve weight loss goals, which not only improve patients' overall health, but also can improve their fatty liver. Now, GLP-1 receptor agonists also lower blood glucose and can contribute to weight loss. So what are the role of GLP-RAs in hepatology practice? Well, we're familiar with semaglutide. This is a 2.4 milligram once weekly dosing that successfully met both primary histologic endpoints at 72 weeks, which showed significant MASH resolution without worsening fibrosis and significant improvement in liver fibrosis without worsening MASH. You can consider administering GLP-1s for overweight MASLD patients with a higher priority given to those with MASH or fibrosis, but not necessarily for lean MASH. How do GLP-1s affect GI providers? Well, it can affect gastric emptying. This can cause delayed gastric emptying. If a patient has a planned procedure, then if they're taking a GLP-1 and because of the risk of causing delayed gastric emptying, this can also increase the risk of aspiration in a patient that's undergoing anesthesia. What the recommendation is that a patient needs to hold their GLP-1 7 days prior to their scheduled GI procedure, whether that be EGD, which is esophagogastroduodenoscopy, or colonoscopy, as again, there are increased risks with administering anesthesia. If that can't be obtained, or entertained, then you might need to consider having the procedure rescheduled for a different time in which they can hold that a week prior to. So let's discuss vitamin E. So this is an old medication that's readily available, and ASLD guidance suggests that vitamin E can be considered in patients as it can improve NASH in some patients without diabetes. Now, the patients do not need to be diabetic and they cannot have cirrhosis. There was a PIVENS trial that was conducted. It was a landmark study that showed vitamin E improved liver histology and in patients that are non-diabetic with MASLD. About 43% of the patients showed histological improvements. Now, limitations, not everybody responded, and you can't use these in somebody that's diabetic or with hypertension. Now, again, guidelines suggest that ASLD recommends that you can use vitamin E in patients that are non-diabetic, but EASL guidelines suggested that because of the limited efficacy on fibrosis and potential risk, which we'll talk about below, that they do not recommend it for MASH therapy, but ASLD is demonstrating that you can consider use. Potential risks include bleeding and prostate cancer concerns, so this warrants cautious consideration and patient discussion, contributing to your interaction with the patient if you're considering starting this regarding long-term high-dose usage. Pioglitazone, this is an anti-diabetic drug that's administered to 30 to 45 milligrams a day. It's indicated for MASH patients with or without type 2 diabetes. The PIVENS trial did show that there is no benefit of pioglitazone over placebo for the primary outcome of improvement in histologic features of MASH. However, the significant benefits of pioglitazone were observed, and some of the secondary outcomes showed some improvement with cardiovascular risk. Now, safety considerations: patients on pioglitazone can gain weight, they can develop edema, their risk for bone fractures can increase, especially in women, and you have to be mindful that there may be a possible association with increased risk of bladder cancer, which again would necessitate careful monitoring and selection of patients who you choose to place this on. So Resmetirom, this is a drug approved for MASLD, for MASH with patients with F2 to F3 fibrosis. This was approved by the FDA in conjunction with diet and exercise for the treatment of adults with non-cirrhotic, non-alcoholic steatohepatitis, now also known as MASH, with moderate to advanced fibrosis, consistent with F2 to F3 fibrosis. This works on the thyroid hormone receptor beta agonist and selectively binds and activates to the beta thyroid receptor in the liver. All right, so the production of thyroid hormones is regulated by the hypothalamic and pituitary activity through the thyroid stimulating hormone. This can regulate many metabolic activities in several systems in the body, including the liver. The thyroid receptor has two isoforms. You have the beta, which is predominant isoform in the liver. Now, the good thing is that the beta thyroid works mainly in the liver. The alpha thyroid agonist is where your main thyroid gland is worked. So this agonist is particularly for the liver. And so what this does is when you have selective target of the liver with the beta thyroid agonist, the mechanism of actions in treating MASH include lipid metabolism. This activates beta thyroid in the hepatocytes that can upregulate genes involving fatty acid oxidation and lipid metabolism. It also helps break down excessive fat in the liver and also increase the expression of bile acid synthesis enzymes, promoting cholesterol conversion to bile acids and enhancing cholesterol efflux from the liver. This increases mitochondrial biogenesis and removes unhealthy mitochondria, leading to increased capacity to metabolize free fatty acids. So MAESTRO-NASH is an ongoing phase 3 randomized controlled trial of resmetirom with patients with NASH. The name is still NASH according to the study, but we do refer to it as NASH now. That dealt with control of resmetirom with liver fibrosis. So this was a trial that studied adults with biopsy-confirmed NASH with fibrosis staging of F1B, which was close to F2, and F2 or F3. 966 patients were randomly assigned in a 1:1:1 ratio to receive once only daily resmetirom at 80 milligram dosing, 100 milligram dosing, or placebo. The two primary endpoints at week 52, there was evidence of NASH resolution, including a reduction of NAFLD activity score greater than 2 points with no worsening of fibrosis, and an improvement or reduction in fibrosis by at least one stage with no worsening. Again, this was accelerated approval, which allows the opportunity for us to have access to this medication sooner. There is a 54-month study going on that's going to assess clinical benefit after 54 months of resmetirom treatment. So safety, when we look at the MAESTRO-NASH phase 3 safety, diarrhea and nausea were more frequent with resmetirom than placebo, and the incidence of serious adverse effects were similar across all trial groups. Now, one thing to know, nausea and diarrhea were more frequent, but they were actually self-limited as well. So when you look at primary endpoints, resmetirom 80 milligram and 100 milligram dosing were superior to placebo with respect to NASH resolution and improvement in liver fibrosis by at least one stage. So practical considerations for managing MASH with resmetirom. You want to consider this for adults who have no evidence for cirrhosis. You want to consider this with patients with moderate to advanced liver fibrosis, state with F2 or F3. And again, this is only approved in conjunction with diet and exercise. All right, so what are some drug-to-drug interactions? Well, medications you want to avoid are listed here to the left. So these are your C28 and OAT-PB1/3 inhibitors. So as you see listed, gemfibrozil, cyclosporin, ritonavir, atazanavir, darunavir, lopinavir, volixiprevir, clarithromycin, etrimovac, torafamide, and leflutamide. Now tolerated with resmetirom, but reduction of resmetirom dosing, it would be clopidogrel, deferox, and trimethoprim. As far as medications that can cause risk of increased exposure due to resmetirom, so repaglinide, pioglitazone, you want to use a max dose at 15 milligrams a day if you're using with resmetirom, rosiglitazone, lamotrigine, montelukast. And then as far as statins, you can use statins, but you want to keep the dose low because this can interact with resmetirom and create statin-like interactions. So pravastatin, 40 milligram dosing, simvastatin, 20 milligram dosing, and atorvastatin, rosuvastatin dosing, as you can see. All right, so duration of treatment and monitoring. So ongoing eval of this continues with the MAESTRO-NASH trial. You'll likely need to restage fibrosis with non-invasive testing to include vibration-controlled transient elastography if you have access to MRI, PDFF, or CAP score with FibroScan or ELF. Depending on your previous baseline fibrosis assessment tool, you want to use that same tool in order to reassess. Expert panels are currently working on cut points and periodic testing on when we should consider this. What I do know as of right now, the ASLD has published some guidelines suggesting that if after a year you don't see much significant improvement in fibrosis, then the opportunity to consider stopping therapy can exist. Again, be consistent with your non-invasive fibrosis testing that you used at baseline and at the conclusion of 52 weeks. So what are some questions that remain regarding MASH with resmetirom? Usage will depend on insurance coverage. We know that there are certain payers that require us to counsel heavily on the front end regarding diet, exercise, and weight loss prior to approval for treatment with this medication. Again, periodic staging and lab testing for monitoring. We do have some guidelines published by the ASLD regarding how often to monitor labs, as well as fibrosis reassessment. Now, they're studying this medication in a longer trial to see the efficacy as far as do we go beyond a year to treat these patients with medication, but those guidelines are being published soon and are going to be readily available soon. So at the meantime, look into ALCD guidelines for a reference point as far as what to do with your patients on resmetirom at this time. And again, with regards to managing MASH, multiple agents are currently in clinical trials and will have more options available in the future. All right, feel free to scan this QR code. Madrigal was kind enough to support this education format. This QR code will allow you the opportunity to visit the GAP MASLD MASH Community Network to review a Madrigal MASH disease state education and Madrigal Resdiffra promotional program. If you have any questions, and please feel free to reach out. It's such a pleasure being able to present to you. Please come find me on my community network. I'm happy to network with you. If you have any questions available regarding this presentation or other presentations in the future, I'm happy to answer anything you have. I wish you well and have a wonderful afternoon, and thank you for joining.